Hi, everyone, and welcome to our Nerva by Mindset Health webinar series. We are very, very lucky to have Dr. Emily Ward with us to present on the great imitators of IBS, diagnoses that fool the scope. And without further ado, I will pass it over to Dr. Emily Ward, who is the founder of Gutsy RX and a board-certified gastroenterologist. And we are very lucky to have her here presenting with us.
Hi everyone. I'm Emily Ward. I'm so happy to be here presenting the great imitators of IBS, diagnoses that fool the scope. I think this will be a really lovely presentation, and I hope you enjoyed it as well. But I am a traditionally trained gastroenterologist, but I commonly identify as a mom. And I think many women in medicine probably do this. Like, I'm a mom first. And I happen to be a mom of a very allergenic family. So I live and breathe Ingredients Matters. And that is one of the pillars of Gutsy RX, which is a women's gut and rectal health marketplace and virtual clinic. Like, all the products are very clean, without fillers, color dyes, FODMAPs, preservatives, things that disrupt gut health. And for almost 10 years, I was in private practice and primarily the only lady gastroenterologist in my practice. So besides seeing patients with irritable bowel syndrome, I became excellent at colonoscopy. So I would say that's one of my top three things that I'm really good at, besides baking muffins for my kids. So in our Q&A, if you want to pop in there what you're really good at the beginning, that'd be great for me to kind of get to know you as well. So today we're going to go over to know when to question an existing IBS diagnosis, recognizing clinical situations in which the initial IBS diagnosis deserves a second look. So this is very common in my practice. We're going to define what is an IBS imitator. We're going to review prevalence as well as some cases that I saw in practice where the diagnosis of IBS was overturned. And while we're going through this presentation, I encourage you to think about adopting a whole story mindset and remember that as providers, as clinicians, to be a great physician, you must understand the whole story. So we all know this. We all know the criteria for irritable bowel syndrome, and we, based on guidelines, are supposed to be saying to our patients, your symptoms meet the criteria for irritable bowel syndrome. You have irritable bowel syndrome because you have abdominal pain one or more day a week. It's associated with change in bowel habits, change in frequency, change in form. You've had it for several months with the onset of at least 6 months ago. And this is your subtype, and this is how we're going to help you. So we should be saying this in a positive manner, not an exclusatory manner, even though my presentation is about imitators. And that's what you kind of could think about yourself. I think about myself as a little bit of a diagnostician in regards to stats. When I'm listening to the patient and I'm getting that thorough history, doing the thorough evaluation that guidelines tell us to do, I'm building the pretest probability. And when you add the more criteria to that, as well as minimal testing, you get a pretty accurate diagnosis, right? And I think when we're seeing patients in clinic and we're evaluating them for irritable bowel syndrome, when we pick up alarm symptoms, that is easy for us to say, yes, we need more testing, which the alarm symptoms being weight loss, bleeding, anemia, waking up in the middle of the night to have a bowel movement. And of course, we're always on our radar, double checking we're not missing a colorectal cancer. So those greater than age 45 without a prior colonoscopy, all these things give us leverage, give us information to move on to do further testing. And if it was only this easy, Aziz et al. Wrote a really nice review on IBS masqueraders and overlap syndrome. And if we are going down this algorithm, we have somebody that meets the criteria, no alarm symptoms, up diagnosis IBS, further, we'll do our integrated care therapy. But we know a lot of our patients kind of hang out here. They don't get better. They don't feel better. They might seek second opinions and go to different practices to see other doctors. So what do I mean about an imitator? What is an imitator? Why am I not using the word mimic or masquerader? Well, for the purposes of this presentation, I'm talking about a diagnosis that initially meets criteria for IBS, but has a distinct underlying pathophysiology requiring different testing and treatment, and a diagnosis that better explains the symptoms, thus the diagnosis in IBS. And this can't be initially missed on endoscopy, but also diagnosed by endoscopy when there's special attention to detail. So we all read the guidelines, and we are all told that endoscopy is very more yield in this setting. But I think if you're paying special attention to the whole story in detail, you can really have a higher yield result from your endoscopic procedures. And back to diagnoses that fool the scope or fool the endoscopist. So, it really is the endoscopist going in with intention and knowing the whole story that will get to a more accurate diagnosis. So I really try to answer this question for you. As a private practice doctor, I'm always people tease me and say I'm a little bit of a professor because I do look through the literature, look through the research, try to get the evidence. So how often does a second opinion overturn the diagnosis of IBS? Well, it kind of depends. It depends where the patient is. If they're in the community and there's a couple more tests done, it's really unlikely that you're going to yield a different diagnosis than IBS. If the patient is having an IBS subtype of IBS-D or IBS diarrhea, and you're in the community and you repeat a colonoscopy, even though they've had a screening, you repeat a colonoscopy to do colonic biopsies, you might change the diagnosis 12% of the time, with the majority of these being a diagnosis we'll talk about a lot called microscopic colitis. But if a patient is sent to a specialist clinic, tertiary care center, academic center, a person identifying them as a specialist, identifying themselves as a specialist, and that specialist goes in with a mindset of, I'm going to look for these top IBS imitators, then you could up to 50% of the time overturn that diagnosis. So that's what I go with in my clinic when I'm seeing a patient, that maybe 50% of the time a patient given the initial diagnosis of IBS could get a new diagnosis, because I'm sitting here in my specialist chair with my specialist hat, and these patients are being referred because they're not getting better on their therapy, or they're dissatisfied, or there's a lot of heightened emotions in these situations where they feel like they've been dismissed, especially in our current medical infrastructure and the fast-paced nature of our clinics. And when I'm seeing patients, it's patients, like especially women who have IBS-D, they're more likely to have the IBS diagnosis overturned. So this is kind of what I'm thinking in the background when I'm seeing patients in my clinic. And just to reiterate what matters, so category matters. So patients with IBS-D or IBS mixed are more likely to have an alternative diagnosis compared to IBS-C, and women are more likely to have a diagnosis of IBS overturned as well. So what's going on? I thought you said at the beginning, with the thorough evaluation and the Rome 4 criteria and minimal testing, we're getting a really high accuracy in diagnosis. But this is our modern day medical infrastructure. It takes 40 plus days to see a gastroenterologist. When you do, the average clinic visit is 20 minutes long. There's a symptom checklist that the patient's done before the visit, in the waiting room, through the medical assistant. And really, are we really getting the whole story at the time of consultation? I do question that. We have open access endoscopy centers, which are so helpful to get people in for screening and surveillance procedures. But when people are coming with symptoms, sometimes the history is very brief and more focused on the anesthesia and the procedure, as opposed to why they are there for their endoscopic procedure. And of course, there's financial concern. Doing exhaustive testing is very burdensome on society at large, but there's also concern between the patient and doctor level too. We don't want to rack up a huge bill for a patient just trying to get to all the exclusions for IBS. So, this is what's at interplay here. when we're seeing patients in the real world. So what I've come to with my years of experience is the top 10 IBS imitators that I'm looking for when I'm going in and doing endoscopy, especially second look endoscopy. And I put them on this IBS imitator wheel here. And I divided them up to what is typically considered and what we frequently miss or just don't think about. And this darker purple here, I'm always double checking about a proper former colonoscopy for ruling out colon cancer. Minimal testing is targeted towards celiac and inflammatory bowel diseases. But when you look at the literature, what is actually pretty prevalent as an IBS imitator is also disaccharide base deficiency, like lactase and sucrase deficiency, bowel acid malabsorption. We may not be thinking about these so much. In my practice, it's not uncommon to find a chronic infection in the duodenum when biopsied, find abnormalities in the stomach, such as an atrophic gastritis, especially autoimmune type, leading to low acid. And an emerging imitator is extrapancreatic insufficiency, which has gotten a lot of press in the last few years as well. So these are what we're going to be going over in the remaining time. When do you think about challenging the diagnosis of IBS? Well, IBS, this is a hard one, and I feel like this can be a presentation in and of itself. When does an IBS therapy fail? Because in clinic, are we truly applying the integrative approach that our societies want us to in regards to everybody seeing a registered dietitian, offering ways for patients to have gut-brain therapy, even just saying that to a patient? How often actually does this happen? I think gastroenterologists more often are on the pharmacologic options, especially in clinic. And when I was researching this question as well, it's like ineffective after 12 weeks. We know our patients are not going to wait 12 weeks to change therapies or ask for more help, right? Not with portal messaging and phone calls. We're getting communication more like 12 hours, 24 hours later. If you are the specialist and sitting in the specialist chair, that question is probably already answered for you when the patient shows up. Like, they are indeed looking for a second opinion, expectations are higher. You feel a little more compelled to spend time with this case, trying to get that thorough evaluation, trying to get other evidence as to what else can I look for in a targeted fashion. And sometimes patients have been very accepting of the IBS diagnosis, but they come into your clinic and you look through all the notes that say IBS and you're like, this is not IBS. And you just know that something doesn't add up and you need to do further evaluation. So when I'm doing this and seeing patients in clinic, I definitely go back to my internist, and I was an internist pediatrician before I was a gastroenterologist. I go back to those detailed days. I'm looking through the previous labs, what was done, what is missing, is there micronutrient deficiencies. I look at previous gastroenterologist reports or imaging where biopsies done with colonoscopy complete, especially with the ileum inspected. I'm looking at slide reports or having slides sent to my GI trained pathologist for review. And there are many times when there is a diagnosis with all this data that can be given alternatively from irritable bowel syndrome. So as we go into our IBS imitators and cases, I just wanted to update everybody about what is a GI scope, what is an upper endoscopy and colonoscopy. So this is me on many days of the week. I'm passing a long flexible tube with a super fancy camera on the end and looking at the gastrointestinal tract from the inside. We could do lots of sampling from in here, including biopsies. So an upper endoscopy is where you pass the upper scope in the mouth, esophagus, stomach, and upper small bowel. And a lower colonoscopy, where what many people know about, you pass the scope in the rectum, left, middle, and right side of the colon, and you can get into this distal small bowel called the ileum. It's very important for our conversation today. And when we uploaded this presentation, I lost a video. I kind of wanted to show you how dynamic endoscopy is. So this is the beginning part of the duodenum. So you go from the stomach to the small bowel called the duodenum, and you go around this curve, and you can even look at where the bile duct inserts and where bile acids help us with our digestion. So that's a little imagery for you there, since we lost video. But when we do biopsies and when we're doing endoscopic procedures and doing biopsies, we're getting a lot of information. So this is a biopsy of the small bowel, these long, beautiful villi that have lactase and sucrase at the end, helping us digest our carbohydrates. But sometimes you could even do a little more. So you could do your endoscopic exam, your histologic exam, and be a little more if you're going in with some mindful intention and knowing the whole story. So we'll go through these imitators. My first 6 slides are just like straight up information about imitators, and my last 4 are real world cases where the IBS diagnosis was overturned. Yeah, so colon cancer, we don't want to miss this, right? It's becoming more common in our younger population, in our millennials and Gen Z. And sometimes people are told that, you had irritable bowel syndrome, and then in retrospect with a colonoscopy, it yields a colon cancer. So in a 2023 meta-analysis of 28,000 colonoscopies performed in those diagnosed with IBS, about 1% revealed colorectal cancer. So it's a low number, but still it's a high-risk situation. And that yield climbs if there are alarm symptoms or the patient is older. But I take this information in context of what's happening real time with this increasing incidence of colorectal cancer in our population. So if somebody's having persistent symptoms, like, I don't hesitate to take a second look. And I think the scope challenge here is sometimes people don't have a completed colonoscopy or their prep was poor, and they leave thinking, oh, my colonoscopy was fine, I don't need to come back. And so you really have to dig the details of this. Was your colonoscopy normal? Do we really have to take a second look, especially to work on that right side? I think Crohn's disease is a big one that I feel we have to be really mindful of. Are we missing this diagnosis? In a population-based study, 1 in 10 patients who eventually have Crohn's were told it's just IBS. And in some cases, this mislabel persisted for up to 5 years. So as we all know, Crohn's disease is a transmural inflammation of the entire gastrointestinal tract. And where I think we can miss this diagnosis, if somebody's had a colonoscopy and the endoscopist just looked at the colon, but didn't look into this lower ileum area, definitely they could have a normal colonoscopy before. And so it's really important to examine the distal ileum. Fecal calprotectin, which is one of our minimal testing markers that's in our guidelines, can be normal in small bowel disease. So you can see how this diagnosis could be missed with more of a cursory evaluation. However, ulcerative colitis is much less often mistaken for IBS because it often presents with bleeding. Fecal calprotectin is almost always elevated in ulcerative colitis. And I think the challenge here is when I see patients, especially younger patients, that are told that they have irritable bowel syndrome and that they're bleeding just from hemorrhoids, I don't accept that. I'm like, nope, we need to take a look. We really need to take a look, regardless of your age. We're going to double check that it's not ulcerative colitis and not early onset colorectal cancer. Bile acid malabsorption. So a meta-analysis on irritable bowel syndrome with diarrhea, about 25% of patients with IBS-D, if tested, will have bile acid malabsorption. So I just wanted to go over this in detail, especially talking about the ileum. So again, you go all the way through and look at this part right here of the small bowel, the ileum. It's very important, your bile acid circulation. So when we eat food, the bile duct will deliver bile acids into your small bowel, which mixes with your food to help with that digestion. And these bile acids are coming from the liver. The gallbladder is the reservoir. Those of you if your patient has a gallbladder that is being put right here. It travels through the digestive tract and then it's resorbed right here in that distal ileum. And plus there is a hormone feedback to the liver saying, don't make any more bile acids. So sometimes this is referred to as an ileal break. But if there's disease here, whether it's from NSAID product, radiation, or it's surgically resected, those bile acids will go unregulated, dump into the colon, and cause diarrhea. There's some testing that's not available in the United States, like CCAT. Sometimes we have the ability to do serum testing for this diagnosis, but a lot of times we're just asking the patient to use a bile acid binder, which is diagnostic. Just the last week, I saw a patient who had an appendectomy, but her scar was a little too extensive to explain just a simple appendectomy. And when we did her colonoscopy, I found out that her ileocecal valve was removed and her ileum distal ileum had been surgically resected or reimplanted in her colon. And she had lived with years of having a diagnosis of irritable bowel syndrome. So I think it's really important that we keep this in mind, especially in our ladies with IBSD. Chronic infection. So we're all aware that a person could have an infection and then develop IBS thereafter. But multiple studies, including a 2022 meta-analysis, showed that Giardia can be detected in roughly 5 to 10% of people who meet Rome criteria for IBS. And, this is not uncommon where somebody has had a previous diarrheal illness and then they go on to having a lot of bloating and gas. And then when they see their provider, stool testing is skipped depending on their provider's targeted testing. A colonoscopy is not in it as normal. But really, a lot of these chronic infections live and invade the upper small bowel. So really here, the scope challenge is, okay, well, maybe we should be biopsying the upper small bowel in certain situations to get to this diagnosis. And so this is the upper duodenum endoscopically here. This is histologic biopsies, the normal lovely villi here, and these are the little infectious trophocytes wreaking havoc on the small bowel. Exocrine pancreatic insufficiency is emerging as something we should be thinking about in patients with IBS. A prospective prevalence study conducted at a tertiary outpatient clinic where they enrolled patients who met Rome 4 criteria for IBS-C. When they tested them, they had about 5% of them had demonstrable exocrine pancreatic insufficiency. And so early on with EPI, sometimes you don't get the history of oily stools or weight loss. Sometimes the fecal elastates can still be normal. And this is, I think, an emerging area where we can use endoscopic ultrasound to help support our diagnosis. So an endoscopic ultrasound is where you go in like an upper endoscopy, but you also have a fancy ultrasound on the end of your scope, and you could look and examine the pancreas really well. Are there changes suggestive of chronic pancreatitis that can help you support this diagnosis? And in some patients, it's very okay to give a trial of pancreatic enzymes. So now we're going into our cases to complete our top 10 IBS imitators. So patient of mine, a 40-year-old female who was referred by her endocrinologist after a new diagnosis for Addison's disease, so an autoimmune disease of the adrenal glands, where she will need support with her cortisol and other hormones. She's been told she's had IBS and complains of having postprandial abdominal pain every day related to change in bowel movements, where her bowel movements become mushy and loose and also less frequent. Pain improves when she has a bowel movement, but she always feels bloated. So we don't need bloating as a diagnostic criteria for IBS. It's very often associated with it. She's tried going dairy-free, gluten-free. She's used the psyllium product Metamucil without any changes, and she currently is eating gluten. She's referred by her endocrinologist because her endocrinologist, well, her celiac testing is normal. Like, is this right? Like, should we do further investigations? And for sake of time, we'll hone in here on her results. So her tissue transglutaminase IgA was normal with a sufficient total IgA level, and her astute endocrinologist went ahead and sent genetics for celiac disease, and she did have a homozygous DQ2 gene permissive profile. So about 40% of the population will have permissive genetics, but only 1% will have the phenotype. So because there's such an association between autoimmune diseases and celiac disease, I did invite her for an upper endoscopy. And what I want to show you here is that somebody with celiac disease can have a nice normal looking duodenum like this, or they can have a scallop duodenum like this. It's half and half. So endoscopically, we're not able to see, and we really need to do biopsies. And so a normal duodenal biopsy will show elongated, lovely villi like here under normal. But those with celiac disease, especially those with longstanding injury, will have intraepithelial lymphocytes, this inflammatory response, and eventually we call this a flattening of the villus atrophy. So this is the case of seronegative celiac disease, which represents about 5% of all biopsy cases. And, you know, we're always thinking about celiac disease with our minimal testing and IBS because 16% of patients with celiac disease are first diagnosed as IBS, but sometimes these serum serologies aren't as accurate as we want them to be. You know, they're very accurate in academic research trials, and then when they get out in the community, they become less accurate. Patients are on and off of gluten, their immune system's changing, they're on immunosuppressive medications. There's all kinds of reasons why you may not pick up, you know, the serology in some of these cases. I think the take-home point from an endoscopic view here is that 50% of patients with celiac disease may have a normal-looking duodenum, so you really should be biopsying no matter what this looks like. So back to, you know, sometimes you can tell there's inflammation here through the scalloping. All right, our next case. A 67-year-old female with at least 10 years of being diagnosed with IBS, mixed picture presenting with concerns of fecal incontinence. She explains that her abdominal pain happens almost every day, and she's uncertain if it's related to food, and her bowel movements fluctuate between mushy and loose and firm and hard. She has such urgency at times that she can't make it to the bathroom in time. So, you know, this is not an uncommon problem, and probably happens a lot more than we're told in clinic. And so it's really important to have a good relationship with your patients over time. The low FODMAP diet has never helped. Imodium and Lomotil make her constipated for weeks. Fiber supplements make her feel more bloated, and in the past, she's tried lots of different things like Vaxin, bile acid binders, Viberzi, Winzets, all over the spectrum of potential IBS therapies. And notice here in these cases how we're not seeing many patients following with a dietitian or doing any sort of brain gut therapies. I think this is, you know, what's happening real time, and maybe people aren't practicing like I am in these days, but you know, these cases you don't hear about that. So to get down to some nitty gritty, she's had 4 screening colonoscopies without biopsy. So again, something that I see routinely where patients have been having symptoms, but they haven't had biopsies of their colon. So after a thorough discussion, I invited her for one more colonoscopy, and this is a big one that is an IBS imitator. Microscopic colitis is truly hidden in plain sight. This is a lovely pink, healthy colon, and biopsies of the colon will reveal a lymphocytic infiltrate in the epithelial area. Sometimes people will also have a collagenous version with a collagenous band here, leading to a secretory diarrhea. So a distinct alternative diagnosis with distinct therapy. And in a meta-analysis, about 30% of patients with microscopic colitis were first diagnosed as IBS. When I'm looking at these cases, I'm also double checking that they were screened for celiac disease, for thyroid issues. There's an association with proton pump inhibitors and NSAID use. I'm not sure if you noticed she had a history of osteoarthritis and was taking NSAIDs intermittently. And again, the scope challenge is that the colon looks normal, and we really have to understand if biopsies were done. So our next patient is a young man, a 19-year-old college Latino with greater than 5 years of IBS-D. He thinks his symptoms are worse after a weekend of partying or eating restaurant food. When he has symptoms, he just quits eating or he eats bananas, and then he eventually might feel better. Otherwise, there's no consistent dietary changes. His prior pediatric workup, he grew and developed normally. He didn't have any weight gain issues. Because he had seen his pediatrician for this, as well as other primary care doctors. He's had some routine labs, including serum celiac screen, H. pylori breath testing. Another provider in my practice saw him and ordered some different breath testing, a SIBO as well as a sucrose breath test. And the sucrose breath test came back positive. And he was referred to me for further discussion. So because of my previous pediatric background and pediatric GI, they're definitely, when they biopsy the duodenum, they'll send for disaccharidase levels. And so this is something that I started routinely doing in cases of bloating and diarrhea and just of uncertain etiology. And also what's happening in the real world is that if patients want to use the enzyme supplement Sucrase, their insurance may only cover it if they have a confirmatory sucrase level on guano biopsies. So that's why this patient was sent to me. And so when I went back, when I'm talking about doing endoscopy and histology and more, this is one of those situations where the upper small bowel, the upper endoscopy will look normal. The villi will look lovely and normal. But then if you send this off for further analysis and ask the lab to run sucrase, isomaltase, and lactase for you, you could definitely get an abnormal result. And in many of the cases where I've done this, it's usually lactase that is low, which is definitely more common in our population. And it's rarely that I get a low sucrase level to support using the sucrase supplement. This perhaps is my most academic slide, but I love it. It's by William Shea and Dr. Brooks, who do a lot of research in IBS. And they evaluated patients with IBS-D, did the guano biopsies, sent for the disaccharidase levels, and about 35% of patients came back as having lactase deficiency and less common sucrase deficiency. And so, with your lactase deficiency history, you might get that the dairy triggers their symptoms. The FODMAP diet could work because it tends to be a dairy-free type of diet, whereas in sucrase deficiency, you might get more of a history of I didn't grow well, I was always bullied as a kid, I always avoid dessert, low FODMAP doesn't help me. So you get a little bit different of a history if you really do a thorough evaluation. All right, our final case here, our final imitator, which is a little more complex. This was a patient who was a 69-year-old female with 5 years of Irritable Bowel Syndrome, mixed phenotype, presenting with continued symptoms. Nothing has worked, right? Emotions are high, nothing's working. I feel dismissed. She feels like food sits in her stomach, and she has some belching. She's very thin, has been thin for many years, and hasn't been able to gain weight. When she's tried lots of things, including peppermint oil, enzyme replacement, Xifaxan, and recently she saw a functional medicine doctor that told her she had low acid, and she wants to know what I think about this. So, back to my looking through the endoscopist lens, I noticed, she has osteoporosis. She's on some sublingual vitamin B12 and other vitamins. She continues to have iron deficiency and B12 deficiency without anemia. Endoscopies are previously performed, but a lot of them weren't with biopsies. And so I invited her back both for an upper endoscopy and colonoscopy, having that intention to see if she had any of these imitators. So something that we're thinking about more, especially in this area, especially when people are utilizing functional medicine who are kind of giving that diagnosis or that root cause of maybe you have low acid. Something that I've been doing is additionally testing the gastric fluid for the acidity level. So this patient, her upper and her stomach looked a little bit red. Biopsies showed an inflammatory infiltrate in her stomach area, in her gastric biopsies here, with paucity of those parietal cells. Parietal cells help make hydrochloric acid. So this is more of like an autoimmune type chronic atrophic gastritis. And she definitely did not have a low pH. Her pH was definitely elevated on the litmus test paper. So I think this is something that we're thinking about. I'm definitely thinking about it. There's case reports suggesting that chronic atrophic gastritis, especially the autoimmune type, can cause this hypochlorhydria, can mimic IBS symptoms. Again, it's more the autoimmune type. A lot of times patients will also have this with Helicobacter pylori infection, which looks definitely totally different on histology. And once treated, the acid level should return to normal. We need proper acid to help us absorb a non-heme iron, as well as help with the absorption pathway of B12. And I think it's really important that patients who are told that they have this low acid hypochlorhydria really do see a gastroenterologist, because some of these atrophic gastritis situations can lead to a precancerous and cancerous type of cellular change in the stomach. So we do mapping of these cases, especially where they have this cellular change called intestinal metaplasia. So I do think it's important that we see these patients with that history. But this whole time, so I went through my list of how I see patients, but this whole time, 50% or more of patients diagnosed as IBS leave the specialist office with the diagnosis of IBS. And so I really truly feel very passionately that bringing this integrative care up front and first in the conversation. Let's do dietary therapy. Let's talk about brain gut therapy. Like, let's do this early. That way, with this, when time goes by, you're making a move and helping our patients in the way they should be cared for. So that's our summary. I hope you have learned something. I hope you learned when to challenge the diagnosis of IBS, especially when patients are women, they're showing up with IBS-D or mixed, when there's a non-response to IBS therapy, or you have a gut feeling and you really feel like you should do further testing. For this presentation, an IBS imitator is a diagnosis that has distinct underlying pathophysiology, has features of IBS, can be missed on endoscopy, but also diagnosed. And the big ones we hit were microscopic colitis, bile acid malabsorption, and disaccharidase deficiency as being the most prevalent IBS imitators. And remember, only when we understand the complete story do we make consistent diagnoses. So I really feel like that's where we're missing a lot of these cases when we're seeing patients, is that our medical infrastructure is just putting a lot of pressure on us, and we're not getting to know the patient in a way that we were trained to. Anyways, I'm happy to take questions, and I really enjoyed giving this talk to you today.
Awesome. Thank you so much. That was a really wonderful talk, and I think just so clinically relevant. We do have a couple questions, so I will jump right into them. Question here: do people with bile acid malabsorption tend to notice diarrhea with specific foods, such as high-fat foods?
Oh, that's such a great question. There's a lot of data out there now in regards to our gut health and high-fat foods, especially like saturated fat dairy, and how it changes our gut microbiota, and it does it through a pathway that's related to bile acids? So the answer is probably yes. They probably do, especially like saturated fat dairy. They might notice a lot more problems. And I'm trying to think if there's any other food associations. Have you noticed anything, or as um, in specifically?
Yeah, I think we could crowdsource it to the chat as well if anyone has noticed anything. Definitely feel free to pop it in the chat. I will move on to the next question. Here's a question. The great majority of people we see in our Facebook groups, Reddit communities, and who write to us through our site FODMAP every day are having problems even receiving diagnoses. Time and again, we hear that GIs do not even do the most basic battery of tests. If they only had you as a doctor, what can patients do to get their doctors to take their symptoms seriously?
Oh my goodness, I hear you. I know. Trying to find the doctor with the personality and the mindset to work on symptoms is a challenge. You know, I I commonly you definitely have to advocate for yourself, and you definitely, if that doctor isn't um you don't feel like that doctor is taking you seriously, like either ask that doctor or ask the practice manager or ask somebody else who has bowel issues, like who are they seeing out in the community. I really think it's you have to network a little bit. And this is exactly what Gutsy RX is about. Like, I took myself out of that private practice scope driven um, place. So I could put consultation up front. So our membership path is all about talking and thorough evaluation and consultation. And I hear you. I hear you as um, not only a doctor but as a patient. Like, I've had that frustrating issue as well. So I think, and I also think that doctors are not fully to blame. They're under a lot of pressure to see a lot of patients in clinic and to cover their overhead, to pay their practice bills, to not have a wait list for their screening colonoscopies. And so, yeah, I in my area, I feel like a lot of patients are seeing their gastroenterologist for their endoscopic procedure, but then they return to their primary care doctor or functional medicine doctor for the rest of their digestive issues, which I don't think is right, but that is what's really happening. And so I think having companies like GutsCRX and having kind of more direct to consumer for gut brain therapy, like Nerva gut brain therapy, is super helpful and modern, and the way we are going to address those issues.
Awesome. On the flip side of that, how do you walk the fine line with patients, sort of the fine line of over testing patients with IBS presenting symptoms? Maybe you can speak to that.
It's so hard. I hear you. I know, like, what is exhaustive testing, right? And so, a little bit when they come to see me, I'm doing what I know I can do through the skill and lens I can do, right? And I'm not testing everybody for alpha-gal syndrome or like deep infiltrating endometriosis or systemic mastocytosis. But like, if I pick something up on their history or talking to the referring doctor, I will initiate that. But I really kind of stick to what I told you here. Additionally, this topic can go on and on and on. Uh, so, I want to be clear that there are other disorders of gut-brain interaction, and especially in the women I'm seeing, there's pelvic floor dysfunction issues. And so there are times when I, don't do this, but if they're more like IBS-C, like I'll go down the more anorectal manometry motility route, with the patient. So I hear you. And again, there's that financial pressure as well. Like, I don't want a situation where I've like strained somebody's, I've made more stress in their life by ordering outrageous amounts of tests. So I do usually stick with this pattern for my IBS-D patients, alternate for my IBS-C patients that and just try to use their history for their pretest probability so you could target the testing, right? So that's what I try to do. I know it's hard.
Yeah, it's definitely a tough and a very fine line to walk. Um, could you speak a little bit about when there actually is, it's not one or the other, there's overlapping DGBI or IBS with
Yes.
maybe an organic disease that's well controlled,
Yes.
and how you manage that with your patients?
Oh my gosh, that happens very commonly, I feel like, especially, so let's say I feel like it happens, and I'll just take the case of microscopic colitis, right? So, you get the diagnosis, they say this, a lot of your symptoms are being caused by microscopic colitis, you initiate therapy, and some symptoms continue. And so, I just treat that as irritable bowel syndrome. And so then you have two diagnoses. And I think what we're not doing a lot in practice is focusing in on dietary therapy and focusing on brain gut. If we could really work with that, I think probably a lot of the pharmacologic therapy would be less often initiated. But in this like fast-paced private practice situation, a lot of times people would be on therapy for microscopic colitis as well as irritable bowel syndrome, right? And so that does happen. There's definitely an association with overlap of IBS with microscopic colitis. I think everybody here, maybe it hasn't been brought up yet, which I'm surprised. Everybody that I see in clinic that has had a diagnosis of IBS, usually they'll have a SIBO breath test. They come in and they kind of get into this a cycle of having antibiotic after antibiotic after antibiotic, but there's an association and overlap between SIBO and IBS, and that's a whole other discussion where you're looking for the reason why they may have had this potentially positive and not false positive SIBO breath test. So yeah, there's several conditions where there's overlap. We talk about it a lot in IBD, right? Like, we definitely see it in IBD, and it's really important to know it's not an inflammatory reason for their symptoms, so they don't keep getting different therapies like immunosuppressants for their IBS. You don't want to give somebody prednisone for their IBS. You want to treat the IBS. So definitely happens, and you have to be very mindful of that.
You got ahead of me with the SIBO question. It was on the list, but it sounds like you've done this presentation before. Couple more questions here. Does CT colonography have a role in diagnosis?
Oh, it definitely has a role in screening average risk individuals. I would not say it has a role in irritable bowel syndrome. In my practice, I've used CT colonography for screening if somebody cannot have a colonoscopy, which that can be various reasons, right? They can't take the anesthesia, right? They've had previous colonoscopies and the doctor hasn't been able to complete the exam because of some anatomic issue, maybe limitations of our scopes, etc. So there are lots of situations where people will go on to have a CT colonography, but not usually in the situation with irritable bowel syndrome. I mean, it's meant to detect polyps, and as a screening option.
Okay, last question here. If symptoms of bloating occur soon after eating instead of hours later, which diagnoses may be more likely?
Oh, that's a great question. I definitely am thinking, definitely that's where I would be thinking like stomach and upper small bowel and my brain when I hear that, or food sitting there or belching or something like indicating more of an upper digestive issue. And yeah, again, a lot of times people are celiac, fecal calprotectin, colonoscopy, and that's like the testing they have. But really, do we need to take a look in their upper digestive tract for those situations? And I think my last case kind of shows that, like, already like sitting there. That's not usually associated with irritable bowel syndrome.
All right, awesome. I know we could answer questions all day, but we will wrap it up there. Thank you so much, Dr. Ward. This was excellent. Please check out Gutsy RX and follow what she's doing there. It's fantastic. Like I said, everyone will get the recording. So if you've registered, then you'll get the recording in an email. And Dr. Ward has also provided a handout that will be sent out in that follow-up email as well. Thank you very much and have a great day.
You too. Thank you, everyone. Bye.